Hi, this is Junaid, and we're going to discuss stroke and DOACs in this lecture. Some off-label use will be discussed. This is for education purposes only. These are my general disclosures. Please pause and review them. So, final summary from the last lecture, which was stroke and atrial fibrillation, that prevalence of Afib is significant and will continue to rise. Calculate the risk of stroke in Afib. CHAS-2 is the best method currently. Stroke severity in Afib, it increases with time. People who has Afib has more severe stroke, and the chances of mortality from that stroke are higher. Anticoagulation is the key, and then also it not only decreases the frequency of stroke, it also decreases the severity of stroke and the mortality from that stroke. And of course, we're going to discuss DOACs actually. NOAC is not the right word to use because it can be misinterpreted in notes to no anticoagulation. So it is better you use DOAC, which is basically DOAC. So objectives are how direct anticoagulations work, what is their role in atrial fibrillation. We'll compare them with Warfarin, clinical issues in management of DOACs, cost effectiveness, and real-world clinical efficacy of DOAC. So this is the coagulation cascade that probably everyone is aware of from med school, the intrinsic pathway and the extrinsic pathway. If you can look at it, the dabigatran actually works on the thrombin 2A receptor, so it's a direct thrombin inhibitor as compared to apixaban, rivaroxaban, and endoxaban, which is a factor 10A inhibitors. On the other hand, Warfarin is a vitamin K factor-based inhibition, so 2, 7, 9, 10. So there is clearly a difference in mechanism of action as far as Warfarin versus dabigatran versus other factor 10A inhibitors. This is another illustration of the same thing. So when we compare vitamin K antagonists, which is basically Warfarin, as compared to NOACs, what is the real comparison? So with Warfarin, we have the ability to monitor, which will come to the next lecture, where I'm going to discuss pharmacodynamics and properties of DOACs, and is it something that we can actually use. They're like Warfarin is definitely less expensive, has a longer half-life, and it is Warfarin. We know that for 50 years, so we have used this medication a lot, and we're very comfortable with it. And then, of course, we used to think that there is a reversible agent for Warfarin and nothing for DOAC, which is not true anymore, and we'll come to that in a minute as well. So NOACs, what is the benefit? It has a rapid onset. I mean, you give the medication and it just works. It has a shorter half-life, which is also really bad in my opinion, but it is what it is. Has a smaller inter-individual variation as compared to Warfarin, as you probably know, that the dosing can severely vary from a very obese person requiring 1 milligram to a BMI of 18 requiring 10 milligrams a day. And DOACs have a simpler dosing, which is a pro and a con in the same time. Definitely has fewer drug interactions, which is very important, as Warfarin interacts with everything, including air. And then there are no food interactions, so patients do not have to worry about their diet as much as how much vitamin K are they getting from greens as compared to Warfarin. So what is the Warfarin problem? The Warfarin problem is that it is underused. As a matter of fact, if you look at this study that has been referenced back in 2010, there were 54 studies shown that were compared, and it is significantly underused, especially in high-risk patients. 29 studies showed that according to 29 studies who should have received oral anticoagulation, 25 reported under-treatment. 21 of 29 showed that anticoagulation treatment levels below 60%. So not only it is underused, it's actually used in less than half the patients. And then in 7 out of 9 studies was actually reported below 70%. So it is a significantly underused medication, and it is not a good thing. The other big problem is that the warfarin, the patients do not stay in the therapeutic INR range. This is another study that basically showed 8 other studies, and that the mean time that the person stays in the therapeutic INR range is only 55%, which is quite low. And community setting, which is like, maybe a PCP or something, it only stays in for 44% of the time. So specialized therapeutic INR clinics actually help, but not significantly. There's a significant cost of warfarin underuse and non-adherence. First of all, it is both prevalent and it's extremely costly because as we all know that atrial fibrillation, which we primarily use this for, is the risk of stroke continues to grow every year. The severity of stroke is higher. The risk of mortality is higher. And if you're not taking the medication that you're supposed to, not only you clinically have a problem, you have a significant economic problem as well, because those patients end up being disabled and taken out of the working force of the community. So DOACs are many different forms. The first one that was actually came on the market was dabigatran. FDA was approved in 2010, and the main study was relay trial. There is a reversal agent that is approved by FDA as well. I don't know how to pronounce that. The other 3, rivaroxaban, apixaban, and doxaban, were subsequently approved by FDA in 2011, 12, and 15 by Rocket AF, Aristotle, and Engage trials, and all of them have a similar FDA approved reversal agent, andexanet alpha. The last one is betrixaban, which has not officially been studied in atrial fibrillation. However, it works on the same principle as factor Xa inhibitor. The study they did was APEX, and that actually looked at inpatient VTE prophylaxis, and potentially the same reversal agent will work on this particular drug as well. So this is not FDA approved for Afib. So the first study is relay study, which was the dabigatran. If you can look at it, stroke or systemic embolism, it was non-inferior to warfarin. Intracranial bleeding, it actually showed, if you look at the p-value, that it is better than warfarin, both at 110 milligrams and 150 milligrams. But overall risk of bleeding, major bleeding, was not statistically significant. Hence, the company never marketed it as a safer medication. However, things are changing. We'll come to that in a minute. Rivaroxaban was the next one, the Rocket Afib steering committee, and that actually showed also non-inferiority to warfarin. Intracranial hemorrhage in this particular study, rivaroxaban, did not show any difference between warfarin and rivaroxaban as far as intracranial bleeding is concerned. And then the Aristotle study, which is apixaban, and you can see the primary outcome is basically that it is non-inferior. However, hemorrhagic stroke, as you can see in apixaban, was technically safer, and not just safer, actually it was, the hazard ratio is 0.15%, which is half technically the risk of bleeding as compared to warfarin. So not only it is non-inferior to warfarin, but the bleeding risk is quite good in apixaban. So AN, American Academy of Neurology, came up with this guideline, evidence-based guideline for the prevention of stroke in non-valvular atrial fibrillation. This was back in 2014, and in patients with atrial fibrillation, as you can see, dabigatran, rivaroxaban, apixaban are probably at least as effective as warfarin in preventing stroke and have a lower risk of intracranial hemorrhage. So clearly it wins, no questions, hands down. But there comes with caveats, and we'll come to that. One more thing to note is that apixaban is likely more effective than aspirin for decreasing stroke risk. Has a bleeding risk similar, I'm sorry, it's not that, let me just go back. That if you look at the apixaban, it actually has a comparable bleeding risk to that of aspirin. So apixaban, on top of this, provides a significant benefit for our patients as far as bleeding risk is concerned. Again, with a caveat, we'll come to it in a minute about the clinical efficacy of these medications. So if you look at it, this meta-analysis, and you can see that warfarin better or competitor better, and as you can clearly see, as far as stroke or systemic embolism is concerned, dabigatran, rivaroxaban, and apixaban is significantly better. Interestingly, a combination of aspirin and Plavix is worse than warfarin, and that is something we need to remember, because people sometimes believe that dual antiplatelet therapy is as good as prevention of stroke as an anticoagulation, which is not true at all. So if you look at the ischemic stroke, let's come to the intracranial bleeding. If you come to the intracranial bleeding portion, you can see that dabigatran, apixaban, and of course aspirin and Plavix is better than warfarin. However, if you can see that apixaban and dabigatran, both of them show significant safety from intracranial bleeding as compared to warfarin. So combined outcomes, as you can see over here, that intracranial bleeding and stroke, both of them are statistically significant when you do the meta-analysis of all three studies combined into one. And this is not something small. We are looking at 28,000 patients and 2,200 patients in warfarin. That's a huge number of patients to compare. So key efficacies of NOACs and from the randomized control trial. Again, dabigatran 110 is not available as a formulary. It's 75 milligrams or 150 milligrams. So we'll just look at 150 milligrams. From an efficacy perspective, apparently, if you look at it, it is slightly superior to warfarin. Major bleeding is comparable, GI bleeding is increased, and intracranial hemorrhage is decreased. Similarly, if you look at apixaban, it is technically superior from stroke and systemic embolisms according to these trials. I mean, clinical trials only. This is not real world data, which we'll come to that in a minute too. But as far as if you combine all this data, you can see that people are boasting that they're generally superior in stroke embolism prevention and have a decreased intracranial hemorrhage. If you look at it, apixaban actually also has a decreased GI bleeding and has a decreased major bleeding. I'm sorry, the GI bleeding is comparable. So if you look at the apixaban, superior, decreased, comparable, decreased, and decreased. And so all in all, choose one. I don't own stocks in any one of them, but definitely better than warfarin on most accounts. Either one you pick, because they're definitely non-inferior, and then intracranial hemorrhage rate is definitely low. So what about specific populations? Because we're all worried about elderly, they fall, and then the chances of them having bleeding is higher, and therefore the warfarin must be better. These are two clinical studies that I'm showing over here, above the age of 75 and above the age of 90, that they are better. NOACs are associated with lower risk of warfarin, a lower risk of intracerebral hemorrhages as compared to warfarin. In specific populations, you can make an argument. So for example, the biggest thing is the CKD, and that is chronic kidney disease for stage 3. There is a dose adjustment requirement for dabigatran and for apixaban, and in basically CKD stage 3, as you can see, apixaban, endoximan, rivaroxaban is better than warfarin. In end-stage renal disease, however, apixaban over here is shown to be better with warfarin. However, if you really look at the data, it is not that significant. So be careful in using in patients with end-stage renal disease. So how do you transition? It's very easy. So for example, low molecular weight heparin, basically Lovenox, you stop the Lovenox, wait for 12 hours, and rather than restarting the Lovenox, to start the NOAC or DOAC. If you have heparin, just stop the heparin, and then this paper actually suggests to starting DOAC immediately. I personally take 2 hours. The real duration of action of heparin is about 4 to 6 hours. So, and then the DOAC getting into the system fully active can take about 2 hours. So I wait about 2 hours till I stop the heparin and then start the DOAC. If you are taking warfarin, hold the warfarin until your INR drops to less than 2 and then start the DOAC. And then if you have to transition from DOAC to warfarin, start the warfarin the minute the INR goes above 1.8, just stop the DOAC. Is it cost effective? It's really a hard thing to measure, but if you really look at it as a combined cost of warfarin, because the medication itself may be cheap, but if you look at the total cost of the patient requiring INR testing, labs, driving to the lab and back, and all those things combined, it is definitely cost effective. May not be in US, because in US nothing is cost effective. However, in other countries, people have done this. This is particularly from New Zealand, that they have found that they have a greater quality of adjusted life expectancy than warfarin. This one is also, I forget where it was done, but again, they're all cost-effective alternatives to warfarin. And the reason is not just the cost of the warfarin, it is actually the cost of the testing as well. As I said, in US, the cost effectiveness is really hard to measure. It's not just the drug cost, it is the anticoagulation, the service cost, and then more importantly, as I told you before, that lability of INR is a big cost concern. And if there's a patient who has labile INRs, DOACs or NOACs are by definition the key to use. If you have a patient on years and years of stable INRs, I wouldn't switch them because it's been working for them. So why rock the boat? So this is a chart that you should actually look at when you are prescribing any of the DOACs. Dabigatran is BID, so is apixaban. I wish they were once daily like rivaroxaban. However, I would still choose dabigatran or apixaban for my patients. Renal clearance, as you can see, dabigatran is the highest, which is 85. So therefore it comes in 2 doses, 150 and 75. So when you go above CKD of 3, you drop it down from 150 milligrams to 75 BID. Similarly, apixaban from 5 milligrams to 2.5 milligrams. Apixaban also has a higher protein bound. So when your intrinsic protein is actually lower, like in elderly situations, so anyone above the age of 80, you should consider dropping the dose as well. So when you are prescribing, this is sort of important to keep in mind. One of the things is the Tmax and T-half values, and as you can see, apixaban is 5 to 13 hours, and then dabigatran is 11 to 17. So it does last a little longer in the system as compared to apixaban, so the overlap is definitely there. However, apixaban, to be honest with you, should be taken religiously on time, because by the 12th, 13th hour, it's already in half. So it is important that you tell that to your patients. Similarly, if you look at the Tmax, its dabigatran is half hour to 2 hours. However, apixaban is 3 to 4 hours. And it makes a difference when you are transitioning. So keep that in mind as well. Is there a role of pharmacokinetic and pharmacodynamic-guided dosing? So this was actually, if you look at the reference, a think tank from the Cardiac Research Safety Consortium stated this, that there's no consensus of using laboratory monitoring or dose adjusting for NOACs. However, they did acknowledge that there will be a risk-benefit trade-off in select patients. And I agree 100%. For all patients, you don't need that. In select patients, for example, renal failure, liver function, low BMI, elderly patients with low metabolic rate, patients on PGP, verapamil combination use, which, by the way, should not be using verapamil. This significantly increases the DOAC concentration in the blood, so please do not use verapamil or any DOACs. And I'm going to get into more of this in my next lecture when I'm going to talk about reversal, where measurement is very important, and are there any tools available, and if so, how to use those tools to measure anticoagulation effect from DOACs. And then finally, the unfortunate truth. Even with all this, anticoagulation prescriptions are low, and less than half of the high-risk patients receive these medications, which is very, very, very unfortunate. I would still like to tell you about this paper that got published in 2018, that there is a higher incidence of stroke in patients taking DOACs. And if you look at this, the way that it collected data, so first of all, if you look at the number of strokes, there's definitely more incidence on patients with NOACs as compared to DOACs and NOACs as compared to Warfarin, and then intracranial hemorrhages were lower as expected. So what they did was that they basically identified a hospital-based massive registry and look at patients who has home medications as anticoagulants, either DOACs or Warfarin, and then they did had atrial fibrillation, and then they were admitted as ischemic stroke, and then they look at the odds ratio that either if they were on Warfarin or DOAC, and were they actually at a higher risk of having stroke. And unfortunately, they found out that the risk of stroke, the patients getting strokes were higher on DOACs with similar basically background profile, because that was important too. Were the patients different? And there were not any difference. As a matter of fact, patients who were on Warfarin had a mean sort of risk slightly higher than patients on DOACs. So keep that in the mind. And then the issue, again, as I told you, is more to do with limitations of our pharmacodynamic monitoring of this medication. And clearly it suggests that DOACs clearly have less anticoagulation and hence also have a safer profile, which may not be the best. And but keep that in mind as you proceed with selection of medications for your patient. One more thing, deciding anticoagulation is not the only thing. You have to decrease the atrial fibrillation burden. So once you have decided on anticoagulation, make sure that you have a core strategy with your cardiologist about rate versus rhythm control, and also look at other risk factors like hypertension, ischemic cardiac disease, and obstructive sleep apnea, etc., and help them improve their quality of life moving further by improving all the other comorbidities as stated. One more thing, I understand that atrial fibrillation can cause you to have an embolic stroke, but that doesn't mean that those patients cannot have a non-cardioembolic stroke. As a matter of fact, in the last lecture we discussed the baseline risk factors are same: hypertension, diabetes, etc. So there's a significantly higher chance of patients showing up with a non-cardioembolic stroke, especially high-grade carotid stenosis or a lacunar kind of a stroke. Please keep that in mind. So if a patient comes in with atrial fibrillation and a new stroke, don't automatically assume that it is cardioembolic. We still have to do a full workup again to determine that if the patient needs an endarterectomy or carotid stenting, or the patient needs to be added on an antiplatelet agent on top of the anticoagulation choice, or switching of the anticoagulation choice. Again, comes with a high risk of bleeding. Keep that in mind. This is a very good review article that is at the end of the footnote from Angiology to read. The next lecture will be a reversal of antithrombotics. As usual, thank you, subscribe and visit.